Welcome to Critical Matters, a sound critical care podcast covering a broad range of topics related to the practice of intensive care medicine. Sound Critical Care provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Today, we will continue with our discussion on acute-on-chronic liver failure with Dr. Rahul Nanchal. This is a continuation of our previous episode where we discussed in detail guidelines related to the management of adult acute and acute-on-chronic liver failure in the ICU. In the first part of our discussion, we talked about cardiovascular and hematologic considerations. Today, we're going to talk about pulmonary, renal, and endocrine considerations to finalize our discussion related to this topic. Rahul, welcome back to Critical Matters.
Thank you, Sergio. Happy to be here.
Obviously, a fascinating topic. We discussed a lot of issues related to acute on chronic liver failure in our previous episode. We dove in a bit more detail to the cardiovascular and hematology considerations. And today we're going to start with pulmonary. And there's a lot we can talk about, but I want to focus on three specific topics: portal pulmonary hypertension, hepatopulmonary syndrome, and hepatic hydrothorax. So why don't we start with portal pulmonary hypertension? Just tell us a little bit about what it is and what are the current recommendations for management.
Sure. So portal pulmonary hypertension is a specific type of pulmonary hypertension that occurs in specifically patients with chronic liver disease. Now, I don't think we need to get in too much into the mechanisms. The mechanisms are complex and probably have to do with changes in the at the level of the pulmonary arterioles combined with the increased flow through the pulmonary system. But just be that as it may, just suffice it to say that these people are at risk for pulmonary hypertension, and especially the liver transplant candidates are being screened all the time, because if you do develop pulmonary hypertension above a certain level, it is actually a contraindication to liver transplant, because people have acute right heart failure during the reperfusion phase once, and basically just a very high incidence of mortality if that happens. And so people are always on the at liver centers. People are always on the lookout for the development of pulmonary hypertension in the context of liver disease. And this is actually a arterial. This is not venous hypertension. This is actually arterial, pulmonary arterial hypertension. So unlike diastolic dysfunction, where the pulmonary hypertension occurs because of pulmonary venous hypertension, this actually occurs is truly a disease that is at the specific at the level of the sort of pulmonary arterioles. And again, Sergio, not a lot of data on what and how to treat this. What we do know is that if you do treat this and people are able to and the pulmonary artery pressures are able to be reduced, people can get liver transplants. And so it's sort of an important entity to think about and sort of start treatment if able. Now, the treatment is what to treat it with is sort of controversial. The reason it is controversial again is because there is not high quality data. There is just one randomized controlled trial which included exclusively portopulmonary hypertension patients, and which showed that macitentan, which is one of the drugs used for pulmonary hypertension, sort of improved hemodynamics and was safe in this population. Another drug, which is called risavuat, was again one of the drugs used for pulmonary hypertension. They had about 13 patients with portopulmonary hypertension in that trial, and so much of the literature that is out there is extrapolated from the broader pulmonary hypertension literature. And although there are some small uncontrolled studies, some small observational studies of pulmonary hypertension directed therapy. What we do know is that we should try and treat this, and we should sort of try and bring the mean pulmonary artery pressure below 35, which is sort of the target for liver transplantation. And again, there was a conditional recommendation. There was low quality of evidence for all of the factors that I have described. But again, this is a unique and one of the very unique entities where it is very specific to liver disease. And and I think treatment of this is probably necessary. Not obviously liver transplantation is sort of the ultimate goal, but even in terms of increasing exercise capacity, quality of life, and things of that nature, I think something that should be considered for treatment.
Excellent. And again, emphasizing that whole concept in clinicians who are not working in transplant centers, they might overlook that even some situations like this, when treated, would make somebody eligible. So it's important to make sure that we have the right referrals and the right support to assure that we're providing the best options for our patients, regardless of what we can offer at our institution or not.
Yeah, absolutely. I think if a person with liver disease gets diagnosed with pulmonary hypertension, that person should likely be referred to a liver transplant center, because again, they probably are the people who have the most experience with what to do and and how to do this, and how to best evaluate so that people become eligible for liver transplants.
Yep. Excellent. The second topic I wanted to ask you about, Rahul, relates to hepatopulmonary syndrome. And I still remember how fascinated I was when I first understood and actually saw at the bedside orthodioxia. And it just illustrates how pathophysiology sometimes can be so interesting from the clinical perspective.
Yeah, this is, again, this is one of the, it is interesting, Sergio, that, these are two opposite ends of the spectrum in terms of, how the pulmonary vascular bed is affected in liver disease. One is the development of portopulmonary hypertension, and, the other is the development of these intravascular pulmonary, some IVPDs, or intravascular pulmonary dilatations, which sort of lead to hypoxemia and, and sometimes refractory hypoxemia. But there is this phenomena called orthodeoxia and pretepnea, which is just the opposite of what you find in heart failure. And so you lay down flat, and your shortness of breath gets better, and your oxygen saturations actually get much better. And so it sort of behaves like a right to left intracardiac shunt at the level of the atrium. Just that it is not. These are pulmonary dilatations at the level of the arterioles and the capillaries, and leading to severe hypoxemia. So again, the interesting thing about hepatopulmonary syndrome, Sergio, is that it is very responsive to liver transplantation, and people can be hypoxemic even after transplantation, and and hypoxemic for a few months. Some people just wonderfully get cured, and we don't know who will and who won't, but there are some people where the hypoxemia even persists, but over time it gets much better. And there is a exception to the liver transplant allocation score for hepatopulmonary syndrome, because if left alone, the people with hepatopulmonary syndrome actually do with exactly the same severity of disease. People with hepatopulmonary syndrome long term tend to do worse than people who don't have hepatopulmonary syndrome, and liver transplantation is actually a good cure. And so the people should be considered for this. There have been a variety of things tried for this. Ultimately, there was only one randomized controlled trial of garlic, which was done in India, and showed some benefit in oxygenation, but it was a very small trial. So in the end, we just ended up saying, by pending liver transplantation, we really don't know how to take care of this. This is just a best practice statement. So please give oxygen and provide supportive care.
And the important aspect of not only recognizing the pathophysiology, which obviously is very interesting for us as clinicians, but the important message seems to be, Rahul, that this is something that is reversible with liver transplant, and that supporting the patients as we get them ready for a liver transplant or as they get evaluated for a potential liver transplant is really what we should be focusing on at the bedside.
Yes, that is true, sir.
The last topic I wanted to talk within the pulmonary realm relates to hepatohydrothorax, which is a difficult clinical situation to manage sometimes, and that is very usual, or something that we see commonly in these patients as they have advanced disease that can cause a lot of symptoms. So what are the thoughts on current thoughts and the recommendation on management of hepatic hydrothorax?
So there was a paucity of data on how to do this, Sergio, and as you have mentioned, this is so ascites, sort of you could, I think in my opinion, ascites is probably more manageable than hepatic hydrothorax in terms of symptoms, because once you develop hepatic hydrothorax, you get, you get this, you get short of breath, and you get this intense respiratory distress, and and things of that nature. And so it is a more difficult entity to manage, in my view, than just ascites. Obviously, TIPS, which decreases the portal pressures, would is very helpful in both in taking care of refractory ascites and hepatic hydrothorax. However, we do know that TIPS also increases the risk of hepatic encephalopathy. It may not be possible in all on all these patients. So if TIPS is not possible, we did say as a best practice statement that the tube thoracostomy with an attempt to pleurodesis should be tried. Now there is sort of a misconception with a slight misconception with tube thoracostomy in these patients as well, that if you do tube thoracostomy, there will be continuous leakage of fluid, there will be electrolyte loss, and things of that nature, or there will be infections. However, most of the studies that have been out there have not really borne this out, and in systematic reviews of just tube thoracostomies for non-malignant effusions in general, rates of spontaneous pleurodesis have been very, very high, including the people with hepatic hydrothorax. And so in an attempt to relieve symptoms and an attempt for palliation, this can be tried with with either either a palliative intent or or spontaneous pleurodesis. In fact, in people who got there is a small series of patients who had tube thoracostomy as a bridge to liver transplant, and there was spontaneous pleurodesis in about 50% of the patients. And so if you do this, it is quite possible that there'll be pleurodesis, and that that you might get rid of the problem.
Excellent. And we did mention the last two that we discussed actually fall within a category that we didn't discuss at the beginning. I just wanted to make sure that we emphasize this to our listeners. We talked about strong recommendations as we recommend. We talked and what that implies. We talked about conditional recommendations as we suggest. And you also have a series of best practice statements. Could you just give us a short commentary, Rahul, on the best practice statement?
Sure. So I think, a best practice statement is a ungraded, strong recommendation, which are developed in in very strict adherence to some guidelines. And the criteria for best practice statements, I think there are 6 criteria for best practice statements. Okay, so one of the criteria is the statement actionable? So if you make a best practice statement, can an action be taken? The second criteria is the message necessary? The third criteria is is the net benefit or harm unequivocal? The fourth criteria is the evidence difficult to connect and summarize. The fifth criteria is the rational explicit, and the sixth criteria is can the grade be formally applied to it. And where a grade cannot be formally applied and the evidence is really difficult to sort of collect, summarize, and use meta-analytic techniques, and there is a question that really needs a statement which is actionable, I think that is how we develop best practice statements. And so I think the panel thought that this was such a common problem that there needed to be some guidance of what to do, but there was not enough evidence where we could sort of summarize it and grade it formally. And so therefore we issued a best practice statement, if that makes sense.
It does. And it's a very important consideration, because you're really identifying as a panel of experts a very relevant clinical issue that clinicians encounter on a regular basis, and providing guidance in those instances, obviously with actionable recommendations, is also very valuable. And like you said, another big part of the effort that you've done with this document and with this whole process is identifying potential gaps in our knowledge that are worth investigating further with research in the future.
Yes.
Excellent. Well, we covered the three pulmonary topics that I think are most germane and relevant to acute and chronic liver failure. There's other things that you talk about in the document that we'll refer our audience to the document to read about, that really relate to how we treat patients with respiratory failure in the ICU in general. But I wanted to move on to the renal considerations, Rahul. And in the renal considerations, obviously, the one and foremost topic for acute and chronic liver failure, from my perspective at least, that I wanted to touch on is the hepatorenal syndrome, often encountered and often misunderstood.
Yes. So, Sajid, can we maybe start with just discussing hepatorenal syndrome, a little bit? I think maybe the general audience may benefit from.
Absolutely.
Yeah. So, traditionally hepatorenal syndrome. So, hepatorenal syndrome, very simply explained, is a non-structural kidney injury that occurs because of the underlying pathophysiology of liver disease, which is splanchnic vasodilation, but intense renal vasoconstriction because of arterial underfilling. So that is sort of, in a very, very succinct way explaining, the pathophysiology of, of liver disease in general and what happens to the kidney. So that, because of arterial underfilling, there is, this intense retention of salt and water because the kidney thinks that it's being underfilled, and that's the whole process of development of ascites and things of that nature. And as the liver disease progresses, as vasodilation progresses, more of this sort of becomes a vicious cycle, and the vasoconstriction in the kidney becomes even more intense, and then and finally the kidneys sort of fail. But really there is not a lot of structural damage to the kidney. So it isn't like, you find tubular necrosis or things of that nature. If you look at the kidney sort of, appears to be structurally normal. And the way we used to diagnose hepatorenal syndrome was that, we would wait for a creatinine to go up to 2.5 in 2 weeks. And then and I'm talking about type 1 hepatorenal syndrome, and there were 2 types, and the definitions have changed. And then we would say, well, okay, now the creatinine is 2.5, it's been a couple of weeks, let's try and give albumin to make sure that people are not hypovolemic. Let's stop the diuretics. Let's make sure that there is no shock. Let's make sure, that it is actually in the context of, cirrhosis and ascites, which is liver disease. And then let's make sure that there is no, structural kidney injury, which means, they would say, or there is no other process going on, which would say, okay, there is no proteinuria, there are no red blood cell casts on urine microscopy, and the renal ultrasound is normal. So that was the definition that we used to use, for hepatorenal syndrome, sort of a acute kidney injury, very, very specific to patients with liver disease. And then we realized that, when we were doing this, we had all of these problems with creatinine because, you wait for a creatinine to go up to 2.5. It may never go up to 2.5 because there's no muscle mass in many of these liver patients, and that we were delaying therapy for too long. And if we delayed therapy for too long, it was people, sort of had, really worse, had bad outcomes. And so as our definitions of acute kidney injury in general evolved, the definitions of acute kidney injury for for liver disease evolved as well. And hepatorenal syndrome type 1 became hepatorenal syndrome AKI, or AKI hepatorenal syndrome. And the definition changed to say, well, if you have a increase of creatinine of 0.3 in 48 hours and you meet the rest of the criteria, that is hepatorenal syndrome. And so it was done in an effort so that we could recognize this early. It took away some of the problems of of waiting for a creatinine of 2.5, and we could start therapy then. So I think now what has happened due to that is that people are very much more attuned to the development of acute kidney injury in people who have liver disease, and much more attuned to the development of hepatorenal syndrome in the in sort of people who have liver disease.
Excellent overview. And with regards to the specific recommendation, it relates to vasopressors. What you'd explained in terms of the pathophysiology is we have severe vasodilation peripherally and severe vasoconstriction at the level of the liver. So I presume that what we're trying to do is increase the perfusion pressure that the kidney sees by raising the pressure of the blood getting there. Is that correct?
Yeah, that's correct. So that's in essence what we are doing. We are trying to constrict these splanchnic splanchnic bed, raise the mean arterial pressure, and direct blood flow to the kidney. So that is in essence what we are trying to do, with these vasopressors. Obviously we are also trying to, make sure that you have adequate circulating volume. So, albumin is sort of become the sort of part of treatment of hepatorenal syndrome. But the specific use of vasoconstrictors in this context is exactly what you described, is to divert blood flow to the kidney and to perfuse the kidney better.
And the recommendation that the guidelines made was to recommend using vasopressors over not using vasopressors in critically ill patients with acute on chronic liver failure who develop hepatorenal syndrome. Any specific comments on the vasopressor that you would recommend?
And this is an area of where people have people have very strong opinions, I think. So telvipressin is not available in the US, and if you look at most of Europe, what is used there is telvipressin. However, if you look at and granted there are not a lot of head-to-head comparisons, but if you do look at a systematic review, and now that has been that was published in the Cochrane database, and I think just underwent a recent revision. They were not able to find any sort of firstly, the evidence was very low quality, but they were not able to find evidence of any of benefit of one vasopressor over the other. So whether you used norepinephrine or you used vasopressin or telvipressin, there was no benefit. There was no difference in outcomes. Now, when you use midodrine and octreotide, there was some suggestion that the reversal of hepatorenal syndrome may be a little delayed by using midodrine and octreotide, which is what we use for splanchnic vasoconstriction, in the United States most often. But again, the quality of evidence was very low. And if you have to, so because telvipressin is not available in the US, if you have to use norepinephrine, that requires a central line, and in most places I would presume admission to the intensive care unit. And midodrine and octreotide can just be given on the floor, and so one has to benefit sort of risks and benefits of doing either. And so therefore our recommendation was general that what if you diagnose vasopressor syndrome, please use a vasopressor agent, and that vasopressor agent could be telvipressin, could be norepinephrine, or midodrine or octreotide.
Excellent. Another important aspect of hepatorenal syndrome relates to the fact that A, it's not reversed or cured with dialysis, but B, it is reversed and cured with a liver transplant. So identifying those patients who are truly candidates for liver transplantation is going to be very important, and also how we would continue to support them if their renal failure deteriorates. Could you comment on that, Rahul, please?
Yeah, sure. So Sergio, you make a wonderful point, an excellent point, that if you develop an uric renal failure with type 1 hepatorenal syndrome, and you're sure it is hepatorenal, so it's not a reversible cause of acute kidney injury, but it is HRH AKI, and you develop an uric renal failure to the point where you're requiring renal replacement therapy. So just placing people on renal replacement therapy does not, it does not recover with just renal replacement therapy. Liver transplantation is what is needed. And so the people who should get, again, the people who should be put on renal replacement therapy are the people who are candidates for liver transplant. And and renal replacement therapy should most often, I would strongly urge people to consider to use in hepatorenal syndrome, to use renal replacement therapy as a bridge to liver transplantation.
Excellent. The final topic I want to ask you about relates to endocrine and nutrition considerations. And I would like to start with the ever ongoing discussion of glucose control. And the guidelines have a strong recommendation for serum glucose control. Could you tell us a little bit more about that, Rahul?
Yeah, so, so these are, so Sergio, these, again, it is difficult to find a randomized, or there is, I shouldn't say it's difficult, there is no randomized controlled trial of glucose control in, people with liver failure. However, we do know generally that tight glucose control or very tight glucose control increases the risk of hypoglycemia. And this is probably way more applicable to people who have liver disease, because they are prone to hypoglycemia for a variety of reasons that I think people are well aware of in any way. And so the consequences of hypoglycemia in first, the occurrence or the chance of occurrence may be underestimated, and the consequences of hyperglycemia may be underestimated as well. There was a few retrospective analyses have shown that people with decompensated cirrhosis had a much higher risk of mortality if they develop hypoglycemia. And so I think while we do not want blood sugars, I think we have moved away from the days where we want blood sugars running in the 300s and 400s from anyone. But I think the risk of hypoglycemia is real, especially for the liver disease population, and that our recommendation was founded on the basis that we should make a recommendation which sort of avoided the risk of hypoglycemia, but at the same time recognized that more than moderate hyperglycemia is more than a little to moderate hypoglycemia is probably not beneficial for patients. And so so extrapolating from the other evidence and the wonderful several meta-analyses that that have been performed, we sort of issued a strong recommendation on on keeping the blood sugar between 110 to 180. Which we felt would sort of balance both worlds, not induce the risk of hypoglycemia and not cause too much hyperglycemia as well.
And this is actually a target that many ICUs have kind of fallen into in guidelines for most critically ill patients. But like you pointed out, in this particular population, hypoglycemia not only can be very recalcitrant to treatment, especially in the acute liver failure,
yep,
but also is associated with high risk.
Correct, sir.
The next question relates to dietary protein load. Obviously, in patients who have chronic liver dysfunction, so that would include our patients with acute on chronic liver dysfunction, we're always worried about hepatic encephalopathy, and there's always been like a kind of a popular conception that if we give them too much protein, they won't be able to metabolize that, and that could be a problem. What is the current thought, and what is the recommendation along those lines?
I think the current thoughts are that if you restrict protein, and even in the patients with liver failure and cirrhotics, all you do is lead to amino acid breakdown, which causes metabolic derangements. The liver, there are reduced glycogen stores. Sorry, there are reduced glycogen stores in people with liver disease, and then when you become critically ill, there is this depletion of carbohydrate stores, and then there is amino acid breakdown. And if you don't feed someone protein, I think this response just gets exacerbated, and it becomes a vicious cycle, and it gets worse. These people, more than others, already have protein. Many of these people already with liver disease already have severe protein calorie malnutrition, and they are not eating well before they become sick in general. And breakdown of amino acids and breakdown of more muscle is probably not a good thing, probably exacerbates all of the metabolic derangements, including hepatic encephalopathy. Now, there's not a lot of direct evidence for what happens, but there are some small trials, and there is one small randomized controlled trial which sort of showed that protein restriction had no benefit on either hepatic encephalopathy or mortality. And so we thought that restricting protein is probably physiologically, sure, there is a small randomized controlled trial, not a whole lot of other data, but just physiologically it does not make sense to recommend restricting protein in these people. In fact, if if enough protein is, the outcomes are probably likely to be better if people are fed, and they are probably in better shape for liver transplantation and so on and so forth, if they get the required protein that they need.
Excellent. And the final considerations I would like to explore, Rahul, relate to medications in patients with acute on chronic liver failure. And there's two aspects that you've commented on the guidelines. One is looking for medication-induced liver failure in these patients, and the other one is to working with our pharmacy colleagues in the dose adjusting. Could you make comments on both of those?
Yeah, sure. So, if you look at the United States, not worldwide, just just we practice here in India. If you look at the United States, and if you look at ALF, although it is rare, or acute liver failure, there about 40 to 50% of acute liver failure is drug related. Obviously, the most common cause is as everyone knows, is acetaminophen or Tylenol, but there are other idiosyncratic drug reactions, herbal medications, and a lot of other recreational drugs, a lot of other things which have been associated with liver injury. So anyone who comes in with ALF and ACLF, and what I forgot to mention, I'm sorry, when in the first part of the talk when we were talking about ACLF, is that at least in the the canonic study, with the European study, where for the first time described this entity, people were able to identify a cause in 60% of the patients. A cause of ACLF was not identified in 40%. And while people think that there could be sort of translocation across the gut of all of these bacterial products, which set up inflammatory response syndromes and things of that nature, it could easily be an overlooked medication. that is causing some sort of drug-induced lung injury that has caused deterioration and acute on chronic liver failure, or even acute liver failure. So I think it is really, really important that and this is a highly overlooked, I think, in clinical practice, and this is applicable to all of us, even at liver transplant centers, that we tend to overlook the and there is some sort of cognitive bias that makes us overlook drugs as an important cause of liver injury or acute and chronic liver failure. And I think a thorough assessment should be done once we are, once our patients are, once our patients present, especially in people, where a cause is not easily identifiable. As to the dose adjustment of medications, I think this, this is very the hepatic metabolism of drugs, and and what happens to the metabolism in acute liver failure or acute on chronic liver failure, especially if people are on ECMO or on RRT, or have Mars circuits, which a lot of liver transplantation centers use, is really underestimated. And I think our pharmacists are the best people. It's always thought of critical care as a team sport, and our pharmacists are really, really important members of the team, and this is where they can be so helpful in dosage, in insert of pharmacological principles and dose adjustments in people who have chronic liver disease, and sort of, because I can guarantee you the metabolism and the pharmacokinetics of many drugs are altered in people who have chronic liver disease or acute liver failure or acute on chronic liver failure.
Excellent. So we discussed a breadth of topics related to this fascinating group of patients with acute on chronic liver failure. I will put a lot of links in our show notes to the guidelines, which I encourage our listeners to read in more detail. Before we go to the closing part of our podcast, Rahul, I just want to kind of reemphasize the 6 strong recommendations that you've all made. Number 1, recommending against the use of hydroxyethyl starch for initial resuscitation in patients with acute on chronic or acute liver failure. Number 2, recommending using norepinephrine as a first-line vasopressor in patients with ALF or ACLF who remain hypotensive despite fluid resuscitation. Number 3, recommend viscoelastic testing, TEG or ROTM, over measuring INR, platelet, fibrinogen in critically ill patients with ALF or ACLF undergoing procedures. Number 4, recommending against the use of electrombopov in acute chronic liver failure patients with thrombocytopenia prior to surgery or invasive procedures. Number 5, recommending using vasopressors over not using vasopressors in critically ill patients with ACLF who develop hepatorenal syndrome. And number 6, recommending targeting a serum glucose of 110 to 180 milligrams per deciliters in patients with acute liver failure or acute on chronic liver failure. Fascinating discussion, Rahul. Now let's move away from clinical medicine, and we'd like to finish the podcast with some questions that are unrelated to the clinical topic. Would that be okay?
Absolutely, Sergio.
The first question relates to books. What book or books have influenced you the most, or what book have you gifted most often to others?
I think the answer to both the questions is the same. So the book I think that has influenced me the most and I've gifted most often is by Daniel Kahneman, called Thinking Fast and Slow.
And just for those who are not aware, Daniel Kahneman is one of the fathers of behavioral economics, of cognitive theory. He obviously got a Nobel Prize for the work that is explained in that fabulous book. Yes. And it has tremendous implication to how we make decisions under uncertainty, which is every day in the ICU. So highly recommend it. We'll put a show link. That is among my favorite books as well, and really a fascinating topic.
It is, and maybe I shouldn't be saying this out aloud, but I have reread the book 6 times now. So,
well, there's nothing wrong with that. We read a lot, but sometimes people recommend that we should perhaps read less books and read the really good books more times. So you're right on track there, Rahul. Definitely a book worth rereading. The second question is, what do you believe to be true in medicine or in life that most other people don't believe, or at least they behave like they don't believe?
Okay, I think Sergio, the answer to the question is probably related to a lot of concepts that are sort of so well elucidated in thinking fast and slow. So what I believe, I think, and perhaps I don't know if how many people believe this or not. Maybe a lot of people do, but I think what I believe is that the greatest hoax of healthcare is that we convince ourselves that all of our actions benefit patients, and I don't think that is true. And I think that we take solace in all of these quality systems and our safety nets and things of that nature, and say, and believe that we are providing really good quality and great healthcare. And what we fail to realize is that these systems and the people who created them suffer from the same cognitive biases that lead to the errors in the first place, and the errors that occur are actually rare and one-off events, and we spend a lot of time sort of discussing those those events, and we don't ask the right questions. Our questions are, oh, what could be done better? Oh, what went wrong, and what could be done better? And where the real question should be, given the exact same set of circumstances, what is the probability that a better decision could be made? And this iatrogenic harm is all around us, and that we should be much more cognitively attuned to the amount of iatrogenic harm that that we cause patients, and that and one of the major iatrogenic harms is diagnostic error, and suffers from again it is all due to the same cognitive biases that are explained, and the behavioral aspects of cognitive decision making theory that are explained in in Daniel Kahneman's book.
The other thing that's very fascinating about this issue that you're mentioning, Rahul, is that two things that I'll comment. One is that COVID has been an exponential lab test for seeing this every day in our behavior and the behavior of our colleagues. The prevalence of these cognitive biases and how they've led people to behave one way or the other is evident every day during this pandemic, and it's definitely worth reading and reconsidering how can we do a better job. And the second aspect that is very relevant, and I was thinking as you were sharing your thoughts, is this whole concept of resulting, where we attach the quality of our decision making to an outcome, yet we fail to recognize that in life in general, but definitely in medicine, luck is a huge component of that. Yep. And you can have perfect reasoning, make the right decision, the patient dies, and we may be thinking, what could we have done differently? What could we do better? Or on the other hand, what I see sometimes is we have horrible reasoning and the patient survives, and we don't question anything because we think we did the right thing. And you were exactly mentioning that, and I believe it's a very powerful concept that all of us as clinicians should have the humility to really reflect on a daily basis.
Absolutely.
The last question relates to what would you want every intensivist who's listening to us to know? Could be a quote, a fact, or something related to what we discussed today.
So so Sergio, I'll leave you with something that has influenced me since I was a medical student. And in India, the book that we used to learn physical examination was called Hutchinson's Clinical Methods. And Hutchison was a fabulous clinician from Britain, and the book's been around since the 1920s. But he had a few lines in there, a quote, which I will tell you, and I think that has influenced me in my practice all my life. So the lines of the quote is as follows: from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us.
That is a very powerful quote, a perfect place to stop, Rahul. I do want to thank you first for the monumental effort that you and your panel did for such a wonderful document in such an important topic for our clinical practice. And second, for giving us the time to discuss these topics in more detail amidst obviously a very difficult surge in Milwaukee and in Wisconsin in general. Please take care. I look forward to seeing you soon again in person, but also having you back on the podcast.
Thank you, my friend.
Thank you for listening to Critical Matters, a Sound Critical Care podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound Critical Care is transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.